Varicella derived from Latin word variola meaning smallpox, while ella means little. So varicella in whole means little smallpox. It is also known as chickenpox, probably derived from the French word pois chiche that means chickpea, indicating the chickpea-sized vesicles seen in this infection. This is a must-know topic for any medical student. So without delay, let's start. Now a bit of knowledge about the virus VZV. It belongs to human herpes virus family and the subfamily is alpha herpes virini, and it is HHV3. VZV is HHV3, HHV1 and 2 is HSV simplex 1 and 2. The characteristic of this family is that there is rapid replication of the virus. The virus is cytolytic and it lies latent in neural tissue. The primary target is the mucoepithelial and T cells, and site of latency is the sensory nerve root ganglion. This virus has double-stranded DNA which is enveloped in a nucleocapsid surrounded by a protein tegument with a lipid envelope with on the surface proteins are glycoproteins. This virus has an enveloped DNA. Coming to host factors, the age of the patient is usually less than 10 years because it attacks mostly the children, and this is in temperate, more commonly seen in temperate zone. But in tropical region, even adults are attacked or infected by this virus. The cases of varicella cluster around winter and spring. The secondary attack rate is about 90%. It may be 60 to 90. This is an exclusive human pathogen. Now coming to the etiopathogenesis. The primary route of infection is inhalation of infected droplets or direct contact with the fluid of the lesions. The infected droplets are then taken up by the second exposed patient. The VZV enters the respiratory tract and causes an upper respiratory tract infection. Local replication of this virus in the regional lymph nodes. Virus enters the bloodstream. This causes primary viremia and it goes to the reticuloendothelial system like liver and spleen and even skin. So the innate immunity in the skin tries to contain the virus, but still the virus overcomes the innate immunity and there is secondary viremia. This causes widespread dissemination of the virus across the whole body. This dissemination causes the vesicular rash on the skin. There is cyclic viremia of this virus and that causes the successive crops of vesicles. The rash is polymorphic. That means at one point of time you can see different stages of the rash. Slowly the cell-mediated immunity of the patient overcomes the virus, leading to recovery but lifelong immunity. The virus then lays latent in the dorsal root ganglion that again can reactivate as herpes zoster. Now coming to the clinical features. The incubation period is 7 to 21 days. There can be a prodrome is 2 to 3 days prior to the rash, usually manifest with fever and malaise, and it is usually seen in adults. Now the rash starts from the face and scalp and then spreads to the trunk. The trunk has the maximum number of vesicles. It then spreads to the upper limbs and lower limbs. This is called centripetal in distribution. The rash starts as an erythema. It very quickly changes into papules, then vesicles, then it might get pus filled and into pustules and then into crust. This is very rapid. It turns into vesicles within a day and it might crust in about day 4 to day 5. It then changes to shallow scars in about 2 to 3 weeks. It comes in crops, so at any point of time the rash is polymorphous. That means you will get all forms of lesions at the same time. You might get an erythema, a papule, a pustule. There are total round about 250 to 500 vesicles in a patient. It comes in 3 to 5 crops in 2 to 4 days. They are tense and unilocular vesicles. This is the characteristic vesicle, a tense unilocular vesicle over a surrounding erythema. Something that resembles a dewdrop on rose petal. So, a dewdrop on rose petal is the name given to the appearance of the vesicle. These vesicles may also involve the mucosa, where it is very transient and you may see shallow ulcers like inside the mouth, nasal mucosa, larynx, pharynx, even GI mucosa might get shallow scars. All these rash is associated with pruritus, and fever comes until the new lesions come. Once the new lesion stops coming, the fever subsides. So this is another case of varicella. Here you can see a lot of vesicles and the size of the vesicle is quite large. When this happens, you should always rule out some underlying immunocompromised state. This was a patient of CKD. So the vesicles were larger and more numerous. This is another variant of varicella, hemorrhagic varicella, which is also called Varicella purpurica. It is a rare, fulminant, potentially life-threatening case. You can see this is a case report by the authors and they have reported this case. You can see how vesicles are blood filled. If you get a case of hemorrhagic varicella, always rule out some immunocompromised state. Here the patient presents hemorrhagic vesicles and crusts and even ecchymosis. They can even have mucosal bleeds. This is a case of emergency. The platelet count is very low. There is chances of DIC. You might also see necrotizing vasculitis in these vesicles. This case was confirmed by Zhang smear which showed the multinuclear giant cells. Since it is a case of emergency, investigations like CBC, PT-INR, PTT, fibrinogen and D-dimer should be done. These patients will need IV acyclovir and aggressive support care. In these patients, you should always find out the retro status. Now coming to the complications of varicella. First and foremost, the skin complications. The vesicle can easily get secondarily infected and may lead to scars. Infected vesicles easily lead to scar, so you should always try to add an antibiotic to prevent the scarring. The secondary infection, if not taken care of, may lead to septicemia as well. Now, when the patient is having hemorrhagic varicella and ecchymosis and petechiae, there is always a chance to develop DIC and widespread hemolysis due to severe thrombocytopenia. And coming to systemic dissemination and complication, there can be fulminant hepatic failure, varicella pneumonia, which is very common and dreaded in pregnancy. There can even be encephalitis, acute post-infectious cerebellar ataxia is common in encephalitis of varicella origin. There is something called Rice syndrome. In this, when a genetically predisposed child is given aspirin for fever in any viral infection, it leads to fulminant hepatic failure and encephalitis. So, always avoid aspirin in a kid. You can give acetaminophen or paracetamol to avoid the risk of Rice syndrome. So, next complication is pregnancy related. There can be maternal varicella, congenital varicella syndrome, neonatal varicella. All these will be dealt in the next class in an elaborate manner, because this is very important for any medical student. They should know this topic in detail. With this, we have come to the end of today's class. I'm trying to build conceptual dermatology brick by brick. Till we meet in the next class, happy learning and bye.